from Siam, which is the old name for Thailand. They were born at the year 1811, and on the year 1820. Her own house, so they lived 3 days in each house, and believe it or not, they fathered 22 children, and they died at the age of 63. This is their picture. For us as surgeons, you can see that the joining is very small bridge of skin and liver, which can be separated in a very small operation. The other famous also conjoined twins were from Bohemia, which is the Czech Republic. They were the Blazek sisters, lived between the year 1878 and the year 1922, Rosa and Josefa. Rosa became pregnant, and she had normal delivery. And to tell us about the cross-circulation, both of them managed to breastfeed. And nobody knew the father, because at those days, they were thought that the conjoined twins were devils, so they were put in an exile, and the physician taking care of them were blamed to be the father of the child. And this is their picture during their pregnancy. Now, in the Arab and Islamic history, I have found that the fairest description of conjoined twins at the time of companion Umar ibn al-Khattab at the year 638, a description of twins with normal upper extremities and also chests. However, they shared one pelvis, and each one of them has one lower extremity. And at those days, they had intelligent questions that we still ask about them. Are we dealing with one body or not? And what to do for the division of will, which is known in the Islamic guidelines. One of the twins died at a few weeks of age, and the other one died 1 hour later. The answers at that time is also intelligent. They said, let's watch their sleeping pattern and their also voiding pattern. And if it happens at the same time, we are dealing with one body. If it happens at 2 different times, we are dealing with 2 different bodies. And I think we don't have much different information in the current scientific era. Now, the first attempt to separate conjoined twins was actually at the, in the history was done in Germany at the year 1495. It was by the butcher type of surgery. One of craniopagus twins died, so they used an axe to separate the other one, so the other one followed by dying from bleeding. But the most intellectual separation was done by a surgeon called Johannes Fatio and described by Koning in the year 1689 by using a constricting band to separate an omphalopagus, which is joining at the abdomen of the twins. And that was done by gradual tightening of the band. And this successfully managed to separate the twins, which we use nowadays for the high fistula and ano. The first successful separation for craniopagus, which is the joining by the head, was done by a surgeon called Voris in France in the year 1957. We see patterns of conjoined twins. We're not sure in plants this is conjoined twins or not, but this is a common pattern that we see. However, in animals, that has been described heavily, and we see that in various types of animals that has been described in the literature. The incidence in Western countries is low. It's 1 in 50 to 1 in 200,000 births. However, it's more common in Southeast Asia and Africa. It is 1 in 14,000 to 1 in 25,000, presumably because of a genetic predisposition for twin pregnancy, which is more in those countries. Interestingly, 60% of conjoined twins are stillborns. They die during birth. And those who live, 40% of them will die within a few days of life. And those who survive, 70% of them are females, which always tells me that the women are more powerful than men. The types, the commonest type is the thoracopagus, which is joining at the chest, followed by the pyopagus, which is joining at the gluteal region, and followed by the ischiopagus, which is the pelvis, and the craniopagus is, and the omphalopagus, which is the abdomen, which is the lowest. And you can see the joining organs in each type. Now, for medical students, they should know these descriptions. Bypass means 2 lower extremities. Tribus means 3 lower extremities. Tetrabus means 4 lower extremities. And the twins are identical twins, having the same monozygotic, monochorionic types, and they are of the same sex and chromosomes. There are also some rare entities which are also put in the types of conjoined twins. Abdominal heteropagus, which is one complete twin and parts of the twin joined at the abdomen. This is called abdominal heteropagus. And duplication of the lower extremities is called caudal duplication. And duplicate head without the rest of the body is called craniopagus parasiticus. And there is parts of the body of a twin inside the abdomen of another twin is called fetus in fetu. Now, the etiology is unknown. Most theories tells us that it is incomplete division of fertilized ova in identical twins. And at between the second and third week of gestation, there is incomplete separation leading to conjoined twins. And nowadays, there are data that presumably there is deficiency of the regulators. There are some types of prostaglandins that are deficient for the completion of the division of the fertilized ova. Now, the diagnosis is important. Nowadays, we have the capability to diagnose as early as 9 weeks of gestation, and it is important because of you can find associated anomalies, and also you can plan abortion for countries that legalize abortion for such anomalies, and also you can also have the ability for potential intervention if you want to do fetal surgery. And you can utilize either ultrasound or echocardiography or MRI. Now, postnatal, there are big lists of tests. You can use all of those tests. However, in our experience, the best diagnostic modality is the high-speed CT scan, which presumably tells you most of the diagnostic data. And you could also utilize ultrasound. MRI is usually used for when there is a neural sharing. You probably would like to use the MRI for more diagnostic information. Conjoined twins is the entity which tells us the importance of multidisciplinary teams, which is actually should be the way to be utilized in modern medicine. You also need to do detailed investigations, and rehearsal is very important for conjoined twins separation and planning. And also you have to have the informed consent and also sharing the data with the parents. And we always utilize written operative plans ahead of surgery. Between 1990 and 2012, we had one team experience of 69 cases. Antenatal diagnosis was achieved in 49 of them, and 49 of them also had delivery by cesarean section. The rest were delivered normally. Those cases are from 17 countries, as you can see the countries. And from our experience, the largest cases were thoracopagus, followed by thoraco-omphalo-ischiopagus, followed by ischiopagus, followed by the parasitic twins, followed by omphalopagus, and followed by pyopagus, and the least are craniopagus. We have operated on 30 twins successfully, and 38 were not amenable for surgery for reasons that I will mention later, and we have 1 twin awaiting for surgery within several days from now. The rationale for non-operative approach, either we have a single heart or major communicating hearts or major anomalies precluding life. These are the examples of those twins that they had either a single heart or sharing hearts, and most of those twins, they don't survive more than a few weeks of life. These are the examples. This is a stillborn case. This is also a single heart, a stillborn case, communicating hearts with major anomalies, and also a double sharing of all parts of the body in a stillborn case, and also a single heart which did not survive more than 10 days of life, and a similar case, and also similar cases, and also major anomalies in the heart with an omphalocele, and also a single heart which is deformed, and also you can have as bad as major natal cleft in such cases, and a double face, and also a stillborn, another stillborn, and a double face case which survived for about 6 weeks, and another communicating hearts with major anomalies, and a small omphalocele, and a single heart in a stillborn, and many examples of those cases. This case is waiting for surgery, which I told you about, that we will be doing within several days from now, with a sharing of the pericardium and liver and bowel. These are the types. I'll just show you the pictures for the sake of our time. This is the first case which we did in 1990, a simple case with sharing of the liver, which we managed to separate at 10 days of life successfully. This is the true first challenge for us, which is we have done in 1992, a case with Xiphoemphaloscupagus tribus, where there is joining of the lower chest, abdomen, and there are 3 lower extremities, 1 for each, and a shared extremity. This case had a sharing of liver and also bowel and genitourinary system and pelvis. The case was done in an 18.5-hour operation. Those are the outcome. They are using prosthesis, and they are now university students. This is abdominal heteropagus, where there is duplication of parts of the body with major omphalocele. These cases are usually simple cases which can be done, and the outcome is usually excellent. This is another challenging case, a Saudi twins that we have seen in 1995, similar to the second case, with sharing of the liver, bowel, genitourinary system, and pelvis. Our plastic surgeons, though I refused, they insisted to use tissue expanders, and we had some problems with them, so I told them to abandon it, because I feel that we overuse tissue expanders in those cases. There is only a limited need for tissue expanders in conjoined twins. So even without the tissue expanders, we managed to separate them and cover them with a filleting of the shared extremity. This is the discharge party of the twins. By the way, at one time, we had 5 conjoined twins in our service, more than hernias and appendix cases. This is Craniopagus parasiticus, a case that had part of the bodies, and that case did not survive because of major communications type D, where there is major communication of the meninges and also parts of the brain and major vascular sharing. This is also another challenging case that was neither the obstetricians nor the pediatricians knew that there is conjoined twins. She had normal delivery, which is actually complicated, and they were born in a small village in Saudi Arabia, and they were transported to our center, and one of them had actually major cardiac anomalies that are needing a transplant for survival. We have did a palliative cardiac procedure early in life, and then went ahead and did the procedure for separation, which lasted for close to 19 hours. We managed to separate them, and this twin, because of his heart condition, needed a heart transplant. The cardiac surgeons felt that it is not feasible, so he died at 6 months of age. The other one is with one lower extremity. He's doing well, and believe it or not, he's a champion in swimming competition. This is a rare entity, which is a triplet pregnancy, where there is 3 daughters. One of them is normal, and the other one we're sharing a pericardium, liver and bowel. We have, they came to us from Sudan, and we managed to do the separation, and the triplets went home in a healthy condition. And this is their picture later on. This is one of the challenging cases from Malaysia. There was an attempted separation early in life, and then they went to England, and then there was a plea in the media, and then they came to our center, and we have done extensive investigation. And as you can see, it's very, very major joining of those twins. We have went ahead and did the surgery. This is the longest surgery we have done. It lasted 23.5 hours. And as you can see, the extent of surgery, how extensive. And the twins did well. And one of the bonding of twins, as soon as they get separated and they wake up, they are looking for each other to look for the bonding of their bodies that they lived for 5.5 years together. And this is their picture coming back for Saudi Arabia for realigning their prostheses. These are the twins from Egypt, Talia and Talin. They also came to us from Egypt, and they had a sharing of liver and bowel. And as you can see, we do the separation of the liver with minimal bleeding. We use the Cavitron and also the argon laser. And with that, you can probably do the whole separation without the need for blood transfusion. By the way, King Abdullah is really keen. He treats those children as his children, and he visits them and sees them because he got really attached to those children, and he helped all of them by not only his sponsorship, but also by his heart. These twins are from the Philippines, Princess Anne and Princess May. They had also a unique entity. They have Escuphagus tetrabus, but also they have cystic adenomatoid malformation in their right lung. And there is a challenge between us and the anesthetist, which one is fairest. So we decided to proceed and resect the middle lobe, which is involved, and then followed by the separation of the twins. The surgery altogether took about 19.5 hours. And you can see how coordination in the operating room is very important to ensure the success of surgery. And they did well. And this is their picture at a later date. Those twins are from Poland, Daria and Olga. They are of the pyophagus type. They have major crossing of the nerves, and their physicians in Poland were worried that they will have permanent handicap. And we have went ahead and did extensive investigations with our neurosurgeons, and we went ahead with the separation, and they did well. And believe it or not, they are walking and running without a handicap, luckily. And this is their picture their mother sent from Poland to us recently. Those twins are also from Egypt, Ala and Wala. They have major cardiac anomalies. You can see in the picture their anomalies. VSD and ASD, and also sharing of the pericardium, and also they have sharing of the duodenum, common bile duct, and a good part of the small bowel. We went ahead and did the surgery for them, and also our cardiac surgeons corrected their cardiac anomaly, and they did very well. Also another Moroccan twins of the Escuphagus tetrabus, which also similar to the Polish twins have some neuronal sharing at the lower spinal canal, which we went ahead and did the separation, and they did also very well and went back to Morocco. This is twins from Iraq. They came to us at the time of no-fly zone, and there was, those twins were very sick in Iraq and at the time of crisis. And King Abdullah directed a medevac plane to go, and we have liaised with the US Army to allow the plane to land, and we managed to bring the plane to, the children to our ICU. They stayed in the pediatric ICU for a good 4 months to stabilize them, and then went ahead and did separation, and they did very well. And King Abdullah visited them in the hospital, and they went back home to Iraq. These twins are from the Cameroon, Pheinbom and Shevoboh, and they also lived in a rural village with the poor parents. And there was a plea in the internet. We brought them to our hospital, did the separation for them. They are of the Zifo Mfalu Escupegus tribus. We did the surgery. One of them had difficulty with her respiration, stayed intubated for good 3 weeks. However, she did well, and they went home, and this is their picture with their family. By the way, the father has 13 children, and these are the twins, the last children they have. These twins are from Saudi Arabia, another challenging case with the Iscu Mfalu Zifo Mfalu Escupegus tribus.
Check one. Okay, Habib.
And we managed to do the separation, and they went home to Al-Madinah al-Munawwara, where they came from. This is another parasitic twin, which is caudal duplication, which also came to us from Saudi Arabia, which we managed to do the removal of the duplicated lower extremity and parts of the bowel. And the surgery was simple, and she did very well, and she went home. This case from Oman of the craniopagus, and we also, this is the cases where you need tissue expander. Very limited cases you need tissue expander. We have done tissue expanders and then went ahead and did the surgery, and the twins, as soon as they woke up, they touched each other and they're smiling. And also the father, just before the separation, had heart attack, so we have also to take care of the father and do for him coronary bypass, and both of them were patients and they did well. And this is their goodbye party. These twins are also from Morocco, sharing of the pericardium, liver, common bile duct, duodenum, and also omphalocele. We have done the surgery. You can see how we use the argon laser for the separation to minimize the bleeding, and they did very well. And you can see the extent of how we do the Roux-en-Y for separated common bile duct. And this is their picture prior to discharge. These twins, again, the second Iraqi twins also, which had sharing of the liver and the bowel. We have done separation for them, and they did well and went home. And this is their mother. These twins also are from Egypt, Escupegus tetrabus, sharing of the lower GI tract and genitourinary systems and pelvis, and the separation was done in a 15-hour surgery successfully, and they went home. These are one of the rare cases where we use what we call exit procedure, where we utilize the placenta to allow us to resuscitate the cases, and because one of the twins had a lethal disease. One of the twins had actually extensive lung disease and also anencephaly, and we have went ahead and resuscitated them and did very rapid surgery to separate the twins, so to salvage this twin. And the surgery was done in 3 hours, and this twin survived and went home. These another twins from Morocco, also sharing of the liver, duodenum, bile ducts, and major omphalocele. The surgery was done, and they did very well and went home. And also, this is another exit procedure for a twin from Bahrain. One of the twins also, as you can see, had major brain anomalies and also lung anomalies, and we have to do very rapid surgery utilizing the resuscitation with the placenta. And we have done the surgery, and the twin did well, and she is now in Bahrain. And we did also reconstruction to ensure her cosmetic outcome is excellent. This is another parasitic twin from Saudi Arabia, which is abdominal heterophagus, which is a simple case which we have done and did well. And this is also another parasitic coded duplication from Syria, which we managed to do, and the outcome was good. And you can see how the surgery was done. And the king, as always, visit them or see them. And this is the twins from Jordan with the sharing of the liver and bowel, which we have done in a 9-hour procedure, and the outcome was excellent. These twins also from Iraq, we've seen them two years ago, of the Pyophagus tetrabas, which we have separated and did well, and they went back home. These are from Algeria, twins also of the Pyophagus type, which we have done last year, and the outcome was as good as you can see here. And this is the surgery. And these are the last twins that we have done from Saudi Arabia, which is the Ischiopagus tetrabas, which we have done in an 11-hour procedure, and the outcome was good. Now, the management of those cases, I must emphasize, it has to be a team approach, and also the multidisciplinary team, both medical and surgical. You have to have a very extensive workup, and you have to have multiple meetings and discussions to ensure that the planning is well organized. You have to involve the parents from the beginning and during the time of surgery and after surgery. Psychological counseling is very important in conjoined twin planning and rehearsal. I must re-emphasize this many times. And you have to control the media, because those cases, the media is very keen and interested. So you have to have a plan to control the media so that it doesn't affect the outcome of surgery. This is how we plan our teams, and we put it in writing, and everybody knows what is the role of each one of them. And also we create multiple small teams, and we have a detailed written operative plan. We have a traffic controller, and we have also, as I mentioned, we minimize tissue expanders, and we also minimize the utilization of prosthetic materials. We have used tissue expanders twice in the series, and prosthetic meshes once in our experience, and our blood loss has always been kept low. This is our operative plan. We also mentioned the timing, who is there and who is not there, and the timing, and this is given to the traffic controller to ensure that nobody enters the room unless that person is requested or asked for. Now, the anesthetic also team, they put their own plans, and they emphasize on color coding. It's very important with the major cases. You have to have color coding, and also you have to have very careful monitoring for the twins to ensure their well-being. Now, as I mentioned, we have a light-mounted camera for the rest of the team to follow what's happening in the conference room. And also, if the media is involved, we have controlled press briefing for them. As I mentioned, we feel that tissue expanders are overused, and their utilization has to be selective. And if you overuse them, you will be faced with complications of infection and unnecessary procedures for the children. And blood loss, if you do it well and you have the right experience and utilize the right technology, it should be minimal. And also, you should continue the post-operative care. You should not forget the team approach, the separation trauma. The older the twins, the more that you have the separation trauma, and that's why we involve psychological and also social counseling for both the children and the parents. Physio and rehab is very important for the success and the outcome of conjoined twins. Now, there is a lot of ethics in conjoined twins. As I mentioned, are we dealing with one body or two bodies? Our belief that if the brains are separate and the hearts are separate, we are dealing with two bodies. If one of them shared, you are dealing with one body. Parent consent is very important. There is a lot of legal issues about parent consent. The biggest case, court case is in England that has been published in many publications. So you have to ensure to get the parents' consent. However, if their consent is against the safety of the children, then you have to have second thoughts. The operative mortality risks, I feel if you don't have a good safety margin, you should be careful not to do conjoined twins. You should not have a major operative mortality in nowadays with conjoined twin surgery. And also you should study the potential and the quality of life after surgery. If you don't provide a good quality of life, then you should be careful whether to do it or not to do it. And if you want to study more, there are lots of literature about the ethics of conjoined twins. And also the other, should we sacrifice one twin at the expense of the other? I don't think we should do that unless one twin is endangering the life of the other twin. If you have shared genitalia, what to do? Try your best to separate the shared genitalia and even the phallus. If it is one phallus, if you follow the blood supply, you will be able to separate the phallus. It is tedious, it has a bleeding loss a little bit, but you should be able to separate the phallus in most cases. Now, there are other ethical issues for adult unseparated twins, what to do about the marriage, and depends on which religion you're following. I think you have to look at that. The murder, if one of them commits a crime, if you punish that, what will happen to the other one? I mean, that's a very ethical issue. And in Islam, the division of will, if there is a death of one of them or the other, or related to the parents. Now, where are we going for the future? Early abortion. Many countries have adopted early abortion. We are also following that in Saudi Arabia. We depend on 3 independent expert physicians and surgeons. And our guidelines, it has to be diagnosed early. We have now the capability to diagnose conjoined twins as early as 9 or 10 weeks of gestation. And if we do that and we have confirmation by 3 independent expert physicians and surgeons, we will abort them. If they only we abort them if we feel they have major anomalies precluding acceptable life. However, if they don't have any anomalies, we allow pregnancy to continue. Fetal surgery is coming in some of the cases of conjoined twins. And as I mentioned, exit procedure should be utilized for cases where you have to do emergency surgery. Now, early abortion, as I mentioned, this is happening in many countries. And also, for fetal surgery, this is one of the cases that has been published where we utilize a catheter to thermocoagulate the blood vessel to slough one of the twins who is endangering the life of the other one. And the exit procedure, I have already talked about it. Now, if you feel conjoined twins are difficult, conjoined twins in triplet pregnancies are more challenging. And the recommendation in the literature are either abortion or fetal reduction for one of the twins or continuation of the pregnancy if there are no major anomalies endangering the life of the conjoined twins. If you feel conjoined twins are difficult, what about triplet conjoined twins? These are the most challenging, and there are only 5 cases being reported in the literature. Luckily, none of them survived, and they are stillborns. Now, this experience told us about building the bonds between the health workers and also the patients and families, and helping the needy, and the exchange of experience. Many physicians from different parts of the world shared with us this experience, and also collaboration with international multidisciplinary teams, and also bridging the religions, because religion does not differentiate between color, religion, or ethics. Patients are patients regardless of their religious or race or country. And in summary, conjoined twins are rare anomalies. We feel that careful and thorough investigations are highly needed. I must emphasize the need for multidisciplinary teams for getting good outcome. And I feel that tissue expanders and prosthetic meshes should be avoided and restricted to very highly selected cases. I feel also early diagnosis with the potential for abortion in selected cases not compatible with life may be considered once ethical and religious aspects have been resolved. And I cannot leave without recognizing His Majesty, the custodian of the two holy mosques, King Abdullah, for sponsoring 69 cases for his humanitarian touch, support, and encouragement. And by the way, this is a party that he put in his farm. We called it Conjoined Twin Party. All the twins were invited to his farm with their families, and this is a group picture with them. And also, I cannot leave without recognizing my colleagues, members of the multidisciplinary teams, for their hard work, dedication, major input, and distinguished team approach. These are examples of the teams who were with us. And I started with the camel and the desert. We moved to the mud houses, and now we are following the sky with the Mecca clock, hoping, racing with the time to help the needy children. Thank you very much.
Thank you very much, Dr. Rabeeah, for this fascinating journey into the surgery of separation of Siamese twins. I thought it was a really excellent talk, and I was really fascinated. And now, it's not usual where we ask people to comment or questions, but I think probably this would be an exception. It's so fascinating that I would actually, if you don't mind, people have any questions? Dr. Ayman, yes.
Transfer abroad. My name is Abdulrahman. I'm the neonatologist in Elham here in UAE. My question to you is, do we have a registry for conjoined twins locally or internationally, so we can register patients who were born locally? Because according to UNICEF statistics in 2010, we get about 92,000 deliveries in UAE annually. So according to the incidence of 1 in 50,000, you get 2 every year. And we don't hear about them, what happened to them, where they go. So is there any plan to have a registry for local, for Gulf, or Middle East, or international?
Thank you, Dr. Ayman. This is a very important question. And data, I'm not aware of any international registry. I think what's available in the registry is what's been published in the literature. However, we have started recently to have a registry, and also we have started to have tissue banking from the conjoined twins. And I must emphasize that any countries who are willing to share with us this experience will be more than happy. Even if they die, we would like to have some data, and we are collecting samples because we feel there is a lot of information that we need to study, and I'm sure that will be reflected in future publications. So we are open. We have now a tissue banking for conjoined twins, and we take samples from the twins and also from their parents. So thank you for this question.
Thank you.
Okay. Well, thank you very much, Dr. Rabeeah.